over to Dr. Poonam to conduct the Jharkhand Ophthalmological Society's session on glaucoma. The instruction part, the introduction part of the discussants and the speakers has already been done. So, Dr. Poonam Singh. Dr. Rashi Shyam. Dr. Tanisha. Yes, Dr. Poonam Singh, please unmute yourself.
Yes, ma'am. Can you hear me, ma'am?
Yes.
Yeah, loud and clear. Yeah.
Okay.
And I think the national speakers should also keep joined in because they can help in, they can play the role of discussants. Okay,
Sure.
Okay, go ahead.
So thank you. First of all, thank you, ma'am, for making me a part of this CME, and a very good evening. And actually, coming back from all the recent advances which we have seen to this basics, which is of utmost importance to diagnose the case of glaucoma. Once we have the diagnosis of glaucoma, then only we can go about all the things which are happening. So as we all know that glaucoma is a chronic progressive disease of optic neuropathy which occurs due to raised intraocular pressure. And this is a condition which can cause, due to progression, it can lead to blindness. So if we diagnose these patients earlier, we can treat them earlier, and if we treat them earlier, we can slow down the rate of progression and prevent blindness. So there are two types of changes which are happening in glaucoma. One are the structural damage which is happening at the level of retinal nerve fiber layer, and it causes the functional damage which we see in the form of visual field changes. So it is rightly said that when we see the visual field changes in the case of glaucoma, almost 60% of the damage is already there. That is the reason why OCT is also known as pre-perimetric test, because it is the test by which we can pick up these cases even when the patient is still asymptomatic, and when the functional by the field changes, when we see it is already too late. So it is a real-time, immediate, objective, quantitative assessment of RNFL. It is a non-invasive, non-contact type of machine where there is a high resolution of cross-sectional images. Now coming to type of analysis. So basically doing analysis at the places where we see the glaucomatous changes maximum are the areas where we have to concentrate. So one is the RNFL, one is the optic nerve head changes, and other is the macular ganglion cell complex. So when we talk about RNFL, it is if you can appreciate here, these are the two areas, wedge-shaped areas here and here, which appear to be little darker as compared to rest of the retina. So basically, the RNFL has a tendency to be shiny, but when the RNFL loss happens in case of glaucoma, these areas appear to be darker. So RFNL scan is done into 3 to 4 millimeter circular scan, which is centered at the optic disc. When we talk about optic nerve head scan, this is basically a scan. All the retinal nerve fibers are actually going into the optic nerve head, and through the parapep, they are going to the optic nerve. So whatever retinal nerve fiber damage is happening in the form of increase in the cup size, increase changes in the cup disc ratio, notching, or thinning of the neuroretinal limb is the area which can be seen in optic nerve head analysis. Then when we come to macular ganglion cell complex, which we most of the times miss out, but we all know that the ganglion cells are maximum present in the macular area. The thickness is almost 3 to 4 layer thick as compared to the other retinal nerve fiber area, other areas of the retina. So this scan is also very much important. Now coming one by one to the various analysis areas to be analyzed. As we have said that RNFL changes precede many other changes in case of glaucoma. So this OCT will do a RNFL assessment from temporal to superior to nasal and inferior in a circular fashion in a 3.4 millimeter diameter of circle. Almost at each point a A scan is taken, and a total of 256 A scans are taken. The speed is almost to the capability of 400 scans per second, and the resolution is 100 micron. Now, with this with this scan, if we talk about it, then these are the various scan of the RNFL which we see here. So let us see, this is a RNFL thickness map, this one. Then there is a TISNET map and there is a RNFL quadrant map. So let us start from quadrant map. So one is the 12 clock hour quadrant map, where we see the thickness of the RNFL against each clock hour. Then when we go to the quadrant, each quadrant is showing the thickness against its whether it is a superior, nasal, inferior, or temporal. Now, the thing to be noticed here is, or to be remembered here, is that green here is the condition which is seen in 95% of the normal population. So green is normal. And if it is yellow, it is seen in 5% of the north. We are actually comparing the whole data with the normative data. So 5% are the patients who are, yellow is the patients seen in 5% of the population, and red is seen in only 1% of the normal population. So red is dangerous. When we come to TISNET map, here this is a map which shows the thickness of the RNFL at the temporal, superior, nasal, and inferior areas. And these are the two lines which show the right and left left side positioning. So here we can see that if at the superior and the inferior area, we can see the thickness of the RNFL is high, which is comparable that we know that in this area, the neuroretinal rim is thicker at the superior and the inferior area. As it is in the form of humps, so it is also known as a double hump pattern also. So here again, if this is present, these lines are present in the greenish area, so they are normal. They are seen in 95% of the normal population. Now we come to the RNFL thickness map. When we see the RNFL thickness map, there is a butterfly type of pattern of parapapillary area, and here the red is normal. So the color coding of the RNFL thickness map is different than the color coding of rest of the quadrant map and the TISNET map. Then we come to the optic nerve head scanning. There, the scanning, depending upon the different type of machines, the previous machine used to give 6 linear scans, spoke-like pattern, which are separated by 30 degrees. These days, the machines have concentric pattern also. This optic nerve head is actually giving us the volumetric changes which are happening at the level of optic nerve in the form of notching, in the form of cup disc ratio, in the form of thinning of the neuroretinal rim. So, and how do we detect the anatomy of the optic nerve head? There are two types of algorithms. One is the reference algorithm, one is the non-reference algorithm. I'm not going into the detail, but the basic thing which is to be known by the students is that when we see these scans, this is the retinal pigment epithelium. And just below the retinal epithelium, this is the choroid. And between them is the Brooks membrane. So the end points of the RPE are the areas which are the optic, which measures the optic disc. And just above it is at a fixed distance. Various machines have different distance, which can be 200 micron, 150 micron, is the area which shows the cup area. And anything beyond that, that is a neuroretinal rim. So these are the various parameters which are shown in the optic nerve head scanning of the OCT. So these are the nerve fiber layers, and the thing we should know is that some machines show the GCC complex, which is the complex of retinal nerve fiber layer and the ganglion cell layer and IPL, and some machines like Spectralis show GCA, which is GCL and IPL, ganglion cell analysis here. When we come to macular scan, basically macular scan tube is centered 6 into 6 millimeter centered at the fovea. There are two types of scans. It can be in 500 by 128 grid or 200 by 200 grid. Taking these many number of scans. So a little more time on this slide is we see that all the fibers from the superior macular area are actually ending in the temporal quadrant, whereas the fibers from the inferior macular area and the parapapillary area are ending in the inferior or temporal inferior junction. So this is usually the inferior fibers are the most affected fibers, and this is the area which is also known as the inferior vulnerability zone. In this macular scan also we see the thickness map. So again, remember the thickness map is a map where red is normal. So here we can see the red color. So the macula is thicker here, RNFL is good here, and here it is less. The opposite of is seen when compared to the normative data of the normal age-related population is the deviation map. So we can, when we compare this to this deviation map, we see the thinning here is seen red here. So the deviation maps show the color coding as red is dangerous. Same we can see in the quadrant map here. So these are how the maps look like. So and these are the basic things which we should be looking in a OCT. Patient data is very important to feed in because we are comparing the data with the age of the patient, the refraction of the patient, and actually when you are going to follow up these patients, you should have a registration ID. Unless we have the proper data, we will not be able to follow up these patients. And especially in an era like this, we have to show the patient at times the diagnostics when you are diagnosing or the progression you are showing. Patient data is very much important. The refraction is also very much important because in myopic patients, due to presence of disc and crescent and everything, the actual OCT may also be variant and may, as already some previous speaker has said, can give a idea that this is also a glaucomatous disc. Then signal strength is very important, which is a fixed measurable for different type of machines. So it can be 6 and it can be 15 microns. So it is varies from machine to machine. Then we come to the RNFL thickness map. RNFL thickness map, as already I have discussed this in the previous slide. This is the thickness map where yellow and red are normal and green is thin. This is the deviation map which compares these data with the normative patients, and in these patients actually the red, when we compare this with the normal population, this is the area where the thinning is present. So these will be shown as in the deviation map. In the testnet map we have already discussed in the previous slides. Quadrant and clock car maps we have already discussed previously. So these are the maps which will tell us the areas where the thinning is present. Then these are the key parameters, some of the key parameters which are fixed, and the red here also shows that with some normative data fixed ratios, they are different. So accordingly, red is serious and yellow is borderline. And then these two horizontal and vertical beams can tell us something about the basic boundaries of the cup and the disc. And then there is the RNFL calculation, which shows that what is the segment, what is the centration of the patient. If the patient is having good centration, and what is the segmentation of the retinal layers in these patients. So how good is the machine when the segmentation is happening? Then we come to the macular cube graph. Here again, this is the thickness map. Almost everything I have discussed here, red is good. Here, red is dangerous. When we see the deviation map with the normative data, this is the macular deviation map, and this is the quadrant map. Now, some machines, the newer machines have guided progression analysis data also, where we can compare the previous ones with the newer ones. So we should also know there are some common misunderstanding in doing OCTs is that the thought, this is common for all the diagnosis, the thought that these devices can diagnose glaucoma in absence of collaborative clinical evidence is dangerous. As my next speaker will be talking about how to clinically see the disc and diagnose glaucoma. So clinical assessment is very much important, and then we should go to the OCT. It is not that on the basis, first we see the pressure and get the diagnosis without seeing the OCT. So all the parameters which will be discussed by the later on speakers are very much important, and correlating them with the diagnostic is the important thing. So limited, the problem with OCTs is that we have only limited normative data. So there are some variations which are there in the optic disc, and we don't have the data by which we can compare these patients. So we cannot totally rely on these diagnostics in patients which have a variable kind of disc. So thank you all. This is all I had to say about the basics of OCT reading. Thank you, ma'am.
Dr. Poonam, you are the coordinator of this session. Okay. So you have to one by one invite all the Jharkhand speakers. So please go ahead. I'm here.
Okay, ma'am. Just a minute. So the next speaker is Rashi ma'am. She will
Dr.
be.
Poonam, can you please stop sharing your slide first?
Yeah,
Because we have already done all the introduction part. Introduction part is completed in front of the national speakers, all the introduction of the speakers and the discussants. So we can go ahead with the presentation.
I hope the slides can be seen.
yes, ma'am.
Okay, so it seems we are going in the reverse order. We did all
Yes.
the recent advances in glaucoma, and now we are slowly going back to the basics. So I was asked to talk about the clinical evaluation of optic nerve head in glaucoma. So we all know chronic progressive optic neuropathy is what causes glaucoma and the disc changes that we see clinically. And we have seen that it is a bundle of nerve fibers that originate in the ganglion cell layer of the retina, and then they converge upon the nerve head, and from there they leave. So we have the physiological cup, and then we have the glaucomatous cup. Now, the physiological cup basically represents the partial or incomplete absence of axons. Pallor of the cup results from the exposure of lamina cribrosa and the lack of glial tissue in the center of the optic nerve head. Neuroretinal rim is the tissue which is between the cup and the disc margin, and it generally, for the thickness of the neuroretinal rim follows the ISNT rule, which we all know. So the inferior rim is the thickest and the temporal rim is the thinnest, even in normal cups. Now, normally, cup disc ratio, maximally we see in the ratio of 0.3:1, which is mostly what is seen. 7:1 cup disc ratio is seen in almost 2% of the population. So lamina cribrosa is the porous region of the sclera, which has the specialized extracellular matrix. And here we have the fenestrations through which all the nerve fibers leave. So basically, understanding the anatomy of the optic nerve head will tell us how slowly glaucoma is damaging that anatomy, and that is what we are seeing clinically. So pathogenesis of the optic nerve head can be because of the mechanical effect, which is because of rise in intraocular pressure, and this forces the lamella cribrosa backwards, disturbing the exoplasmic flow and causing the damage to the nerve fiber layer. And then we have the vascular effect, which is because of the ischemic atrophy of the nerve fibers. So there are certain signs which are suggestive of a glaucomatous optic nerve head. Now, first of all, we have to see the cup size in relation to the total disc size. So we may have a small disc with a deep cup, a medium disc with a deep cup, medium disc with a large cup, and then a large disc with a large cup. Now, which one of these is actually just a normal variation of the cup or a glaucomatous cup? The other soft sign is there may be an asymmetry of 0.2 in both eyes. This is present normally also, but when there is an asymmetry of 0.2 between the two eyes, then it is a red flag. Third is the vertical enlargement of the cup. So vertically CDR ratio is more and horizontally it is less. So this is because we have loss of axons which occur more in the superior and the inferior regions, so that there is more of a neuroretinal rim thinning at the vertical poles. The fourth is there may be a focal atrophy or a polar notching. So focal atrophy is what we see as a notch. It is mostly there in the inferotemporal region. Sometimes it is there in superotemporal region also. And this is a small discrete defect of neural rim tissue loss in that area. Now, this is very important because this is one of the most pathognomonic signs which correlates with the visual field. When we see an inferior notch and we deem it as a glaucomatous thinning, then we should have a superior field loss of an arcuate or a centrocecal or cecal form on the visual field of that eye. Now, as the notching occurs, the adjacent nasal margin border becomes more sharpened. So as the focal defect becomes enlarged and then it deepens, the nasal margins next to the blood vessel, we see it like a sharp margin. And this sharpened rim is because that is where the neuroretinal rim has been lost. So there are certain signs which we see on the optic nerve head of a glaucomatous disc. One of them is bayoneting sign. Now, a bayonet is a kind of protrusion on a handheld rifle from where you have a sharp knife pointing out. So this was used in armies before when you just had two bullets. And when you run out of bullets, then you just charge with the bayonet to stab the person in front of you. So you see it like a double angulation. And this double angulation is the blood vessel. It is going straight, and then it just angles one more time before it goes over the neuroretinal rim. So then you have the laminar dot sign. This is more pronounced appearance of the lamella cribrosa perforations. Here, as there is loss of axon, so it takes on a grayish hue and it has a deep cup. And then you see all these dots, which are the perforations that have become exposed. And this generally happens when there is advanced damage. Third, there is overpass cupping. So initially vessels bridge the deepened cup, and then as the cup further deepens, there is a collapse and the vessel just disappears at the cup margin, and you see the vessel, then you can't trace it anymore. And then you see the vessel coming out from the neuroretinal limb a little more ahead of it. So kinking of vessels at the cup margin is there, and then the color of the cup and the contour of the cup. This is also important. As the enlargement of the cup progresses ahead of the pallor, we can deem it as a glaucomatous optic atrophy. This is opposite to when we see much more pallor and less of cupping. If there is much more pallor, it is a very, very chalky white pale kind of disc, and the cup is not so much. If you can see that the cup is 0.7 or maybe 0.6, and still it is a very, very pale disc, then that is a red flag, but it points towards more neurological cause of the optic nerve head damage occurring. Now, saucerization is when you have a diffuse shallow cupping, and this extends to the disc margin with the retention of central pale cup. You may have focal saucerization also, and these are early signs of glaucoma. Then splinter hemorrhages. Now, splinter hemorrhages are there in normal population also. They are present apart from that, they are present wherever there is an ischemic event close to the optic nerve head or in the peripapillary region. And these splinter hemorrhages are also seen in glaucomas, especially ocular hypertension. And sometimes when a patient is on anti-glaucoma drugs already, and then there is still further damage happening, then the pressures may be fine, but you will see a splinter hemorrhage where further neuroretinal rim damage has occurred. So splinter hemorrhages are also very important when you are trying to carefully see and make things out from the optic nerve head clinical examination. Now, bearing of circumlinear vessels is when there is a space between the neuroretinal rim and the superficial blood vessel, and these blood vessels appear to be bared from the margin. Like normally the vessels move hugging the margin of the neuroretinal rim, but when there is a bearing, this happens in glaucoma when the cupping is enlarging quite fast. Sometimes due to ischemia, you have little tortuosity of the retinal vessels, and you have some neovascularization or collaterals forming. And then you can make out that, okay, there is an ischemic component that is more in this kind of optic nerve head damage. Now, in advanced glaucomatous cupping, we see a bean pod cupping. So nowadays we have an OCT, and sometimes that bean pod shape can be made out very well on the cross section of the cup. So here you have loss of all the neuroretinal tissue. There is total cupping, which is seen as a white disc, and there is bending of the vessel at the margin of the disc. Now, wedge defects are also very important, and wedge defects, we best see it in the red free, and what we see here is a wedge shaped defect which has the apex pointing to the disc margin and then the wedge going away from there. And sometimes there is a disc hemorrhage there as well, and that is where the focal notch is also seen, and this is kind of pathognomonic for a glaucomatous optic nerve head. Now we have the alpha and beta zones and the scleral rib. So it is very important to know the disc margin, and the disc margin we can make out from the scleral rib, which is like a white rim that marks it, and it is the point where you have the anterior extension of the sclera between the choroid and the optic nerve. Now then you have the beta zone, and then you have the alpha zone. So alpha zone is just hypo or hyperpigmentation, and this is a zone which is associated with chorioretinal thinning. So here we can see we've nicely marked out the alpha zone, and it is slightly paler than the rest of it. And then as you go inwards, you have the beta zone, which is more pigmented. And this is because of the loss of RPE and choriocapillaries leaving intact choroidal vasculature. So that was all about the basic characteristics of a glaucomatous disc. And next time when you are doing a clinical examination, I hope all these pointers will help you to clinch your diagnosis. Thank you so much.
Thank you, ma'am, for telling the students one of the basic things which is of utmost importance for in glaucoma. And then another thing which is how to differentiate between the angle closure and open angle glaucoma. Gonioscopy is another very important thing, diagnostics. So I will request Dr. Anandya to take over from here for her talk on gonioscopy.
Thank you, Bharti ma'am. Thank you, Dr. Poonam, for giving this opportunity and everyone in JHOS. So is my slides visible?
Not as yet.
Really?
Yeah. Yes. Now we can see.
Okay. That's great. So let me just change to slide. So yeah, thank you for this opportunity. I'll be going for gonioscopy, and if we'll go through this study, as per the residents, they have reported gonioscopy is the least performed examination by them. So let's focus on what's the difficulty, challenges they go through for gonioscopy. So these are the various kind of gonioscope lens. These are actually indirect gonioscope that we do through the gonio mirror. So this is how the 3-mirror, 4-mirror gonioscopes they look like. So we'll be proceeding with the experience of postgraduate student. Once they go through it, what will happen. So I think the audio is not available, right? Audio is not going on. Okay.
Yes, it is not going.
Yeah, sure. So I'm just going to explain what is happening here. So the PG students is trying to do the gonioscope um, on even optometrist, because the optometrist will be more comfortable in sewing properly. So she is starting with the ideal 4-mirror that we most of the time we use. So it's a like a 4-mirror, so no viscous liquid is required. Just after using paraffin directly, she is trying to put. So I'll be trying to make it little bit faster. Just yeah. Um, yeah. So when she is placing this gonio, you can see what will happen. I'll be taking, yeah, this is what she is observing. She is actually on the skin of the eyelid. What she is trying to find out is cornea, but half of the portion is in the cornea, and you can see the eyelashes also. She is actually on the eyelid. That very easily happen with the 4-mirror because it slips. So for the beginner, that is why 4-mirror becomes difficult. So next, go to the trial with the 3-mirror gonioscope. So once you will start the 3-mirror, because it uses the coupling fluid. So, holding the cornea is easier. It doesn't sleep. Once it holds, then it holds, but it's too large. How difficult it is, to insert. You can see insertion is really, really difficult here. Okay, anyhow, she will be able to insert and is, able to do that. But what she is facing is again, eyelid is slipping. Okay, she tried to fix it. Now but you can see the air bubble inside because the eyelid is coming in between. Eyelashes are there. So once she will pull it, okay, now she is there. But what she is actually seeing is the limbus. It's still not the angle. She is just thinking the cornea, the limbus is where she is, going to see the angle, but it's not like that. She has to move to the mirror to see the angle structure. So now, because 3-mirror is difficult for her to manipulate, so we'll be going for the 2-mirror and see her experience with the 2-mirror gonio lens. Okay, so this is the what she is holding is actually 2 mirror, and see how easily she can insert, though the insertion way is not correct. And she has taken a lot of illumination. This much of illumination will constrict the pupil and go for a wrong recording of the angles. And the room light should not be so bright. But anyhow, the first thing is to insert the gonio properly. So now the scratches you can see, the scratches means you are on the anterior surface of the gonio lens. So now you have to go deep. Well, she is trying to go deep, and now she is, yes, on. So she is on the superior part of the mirror. That means seeing the inferior part of the angle. So the inferior angle is the most open angle. So that's why she is able to see the angle structures. Um, though not so properly focused, at least he is able to find out where is the angle. So now she will, without even changing the hand, she is able to come down and see, and then to the nasal and temporal, just the opposite way has to be seen. Okay, so now we have done a very small survey to understand what's the kind of difficulty resident doctors they go through while doing gonioscopy. One is accessibility to the gonio lens. So in that case, I'll suggest sharing the gonio lens and purchase it for your own. Choosing the right gonio lens to begin with, like 2 mirror, is easier for the beginners. Choosing the right patient, the eye should not be too deep. Little bit protruding eyes will help, especially the myopics, and a cooperative patient, and inhibition in the clarity of the mindset regarding the technique and the learning curve. And it's understanding that it's an invasive procedure, but it's not. It's a touch procedure, not invasive. Obviously, hand stability is required. So first do 90D, then you follow with the gonioscope. Discomfort to the patient creates hesitancy and tendency to grading the ideal positional lighting. That I will strictly say to the beginners, the residents, please do not focus on the very specific, this is the angle, this is the light, this is the how it should be done. Rather focus on insertion. Insertion is the most difficult part in gonioscopy. So once you are able to do that, identifying the angle and grading it, it will happen over time. It has its own learning curve. And over reliability on Van Herrick's and impatience to jump to a diagnosis, the mindset and notion that it is really a super specialization technique to be handled by glaucoma specialist, it's not actually like that. And most of the time residents are not encouraged much. The trainer or consultant does not have the accessibility to the imaging system to identify what the students are actually noticing and where is the difficulty that they are facing. So it's something, obviously the management has to look forward that they should have the imaging system to see for the gonioscope. And the features like, okay, convex iris, it's difficult for the specialist also, so nothing big. So once you have a happy patient to go ahead for the gonioscope, this is how we see all the 4 quadrants. And there are few basic structures. It's all available in the book, so I'm not going into the detail. And this is indentation gonioscope. You can see the this cornea folds. That means indentation is happening. This is not the correct way to see the normal structure angle, but this is just to see whether it's a positional angle closure or a synechial angle closure. So other things like that we can also notice that sometimes the PI can be so small that we have to find out in the gonioscope, and especially because of the arcus annulus, it may be not be visible in the slit lamp. And well, there are a few other things like how much is the pigmentation must be mentioned, because pigment dispersion and pseudoexfoliation is the diagnosis. Sometimes we have to make through gonioscope only because the patient may be pseudophakic, to identify the lens differences. And why should we learn or teach gonioscopy? So coming to our motive behind why should we learn, MIGS can be easily done by phacosurgeons. It's not the place for only glaucoma surgeon. So if you, this is the time that MIGS has a good opportunity. So for MIGS we need to be good in gonioscopy. And of course there are medical legal issues if we fail to identify the angle closure, and the patient may land up with angle closure attack due to using the medication that should not be used. And because glaucoma is a cause of irreversible damage, and the type of glaucoma decides the outcome. So that is why we must understand gonioscopy. Sometimes finding the foreign body also, gonioscopy is required. So these are few literature where there is a specific criteria how to do the best gonioscopy that I will suggest to go ahead. So my topic was gonioscopy. Is it really difficult? So hopefully, once we do it, may not be that difficult. Thank you so much.
Thank you, Dr. Anindya. It was a really pinpointed type of suggestions which you gave, especially initially in initial stages, gonioscopy becomes very difficult, and doing a correct gonioscopy is very much important to know ahead how the things are going about. So then we now come to the last talk of the day, which is very important, last but not the least, very important because and a very difficult one, visual field analysis. So I will request Dr. Tanisha Singh to please join in for the last talk of the day, which is on visual field analysis. Dr. Tanisha, please.
Yes, ma'am. Can you see my screen?
Yes.
Are my slides visible?
Not as yet.
Not yet.
Okay. I'm trying to share my screen somehow. Doesn't seem to work for me.
Ma'am, click on share button at the bottom side, a green color
I'm
button.
clicking on the share
Yeah,
button.
then double click on first option, ma'am. Entire screen के नीचे स्क्रीन और डेस्कटॉप उस पर डबल क्लिक कीजिए मैम.
Entire screen. Yeah. And
एंटायर
share.
स्क्रीन के नीचे स्क्रीन और डेस्कटॉप हाँ पे क्लिक करके तब शेयर कीजिए मैम.
No, I'm only getting 3 options: Chrome tab, window, and entire screen.
हाँ मैम, एंटायर स्क्रीन पे क्लिक कीजिए, फिर एंटायर स्क्रीन के नीचे ऑप्शन होगा मैम स्क्रीन या डेस्कटॉप.
No, that option I'm not getting actually.
एंटायर स्क्रीन पर क्लिक करने पे क्या हो रहा है मैम? एंटायर स्क्रीन पे डबल क्लिक करके शेयर कर दीजिए. क्या आ रहा है मैम लिखकर?
Still not being able to share somehow.
Is your PowerPoint open on your desktop?
Yes, it is. Should I go ahead with without sharing my slides, because I know everybody must be in a hurry?
You can join with your mobile and
No, nobody's tired
No.
because yesterday it was till every day it is till 11:30 p.m. Today it is ending up very early. So relax. Everybody is even madams Shankar Mitralaya consultants have has joined. They have not left. I can see everybody is
Now
Swati
I think
Upadhyay,
I will be
Parivarti
able to
madam,
join.
Rathini madam. Everybody is there.
yeah, please go ahead, ma'am.
Now is it visible?
No, ma'am, not. No, Dr.
क्या बोला?
Tanisha, still
I think that you are not clicking on share. I think that.
So I am clicking upon the share because I've done it so many times. I don't know.
हाँ
आप
प्रेफर्ड
अपनी
प्रैक्टिस पैटर्न
प्रेजेंटेशन किसी
कैसे
को दे
बनेगा?
दीजिए मैम, व्हाट्सएप कर
हाँ
दीजिए,
इसका
वो
फ्लायर
शेयर
अलग
कर देंगे
बनेगा. वही
आपके
तो
यहाँ.
प्रेफर्ड प्रैक्टिस पैटर्न का अलग फ्लायर बना सकता है.
मतलब पांचों में अलग बनेगा।
ये पांचों और ये इनको बहुत धीरे धीरे समझते हो.
See this.
डॉक्टर
भारती मैम
भारती मैम,
म्यूट कर लीजिए,
डॉक्टर भारती मैम,
म्यूट कर लीजिए मैम।
डॉक्टर भारती मैम, क्या आपके एंड पे ये किसी को अपना प्रेजेंटेशन दे सकती हैं जो शेयर कर दे मैम?
See, I'll show you what I'm getting on my screen. I'm sending it to Bharti ma'am. Can somebody help there?
Okay. You have sent me on WhatsApp?
Yes, ma'am.
मैम
ये
अपना
WhatsApp
प्रेजेंटेशन सेंड कीजिए मैम को, भारती मैम को
I
व्हाट्सएप
see.
कर दीजिए.
WhatsApp करो.
कर रही हूँ मैम.
I'm opening my WhatsApp. कैसे करते हैं बताओ? नहीं awesome. Okay.
Yes, ma'am.
Yeah.
Now is it visible?
Yes.
Okay. Right. So I'll just go with the very basics. Have already taken a lot of time. I don't know how that happened. So now the HFA has involved, the field tests have involved from kinetic to static, and also the frequency doubling technology, which is being used with low spatial frequency gratings to target the magnocellular pathway and detect glaucoma early. So the factors influencing the visibility, the first one is the stimulus size. The most commonly used one is the size 3, Goldman size 3. But in patients with advanced diseases who have poor visibility, larger sizes can be used, like the size 5, or in our machines in the Humphrey, we have large diamond, which can be chosen. So coming to the stimulus intensity. So the absolute unit is the apostles, whereas we frequently see in our printouts the decibels, which is the attenuation of the light intensity. So the maximum, the light that is being attenuated can be taken up by the fovea. So we see the maximum is shown at the fovea. And the 0 decibel means even with the maximum intensity of the light, where no attenuation of the light is being done, the 0 decibel is achieved. So you come to background illumination. The standard illumination is 31.5 apostolps. And the color of the stimulus, we use white on white. Sometimes people use the short wavelength, that is blue on yellow. Helps in early detection and isolates the blue cone system. The duration of the stimulus is such that it disappears before the patient can change or shift her or his gaze. And the pupil size should remain same in each of the follow-up visits to avoid the inter-test variabilities. So in certain cases, we can consider dilating the pupil. Coming to the threshold sensitivity, several strategies. The basic that we use is the CETA standard or CETA fast. And the protocols can vary from 30-2. So dash 2 means it's 6 degrees apart. In 24-2, what we do is the nasal 30 degrees of the field is kept, but some of the points from the temporal side are removed. So essentially, we can also go to a 10-2 and macular threshold as the disease advances. So this is the 30-2 where all the points are being studied. In macular threshold, we study 16 central points. So macular threshold is basically helpful in cases where we are suspecting that the patient might end up into a wipeout. So if the fovea is threatened, we can get an idea and prognosticate the patient as such after having a macular threshold printout. In the single field printout, the basic components are the demographic data of the patient, the reliability indices, the raw data and the grayscale, the total deviation and the pattern deviation plot, the global indices, and the glaucoma hemifield test. So the reliability will depend on the perimetrist observation, the patient comfort and head position are of utmost importance. And the patient should be knowing that if the patient needs to shift the head position or make themselves more comfortable, there's a way to pause the test in between and can reposition herself or himself and start the test again. So that should be paid attention to. The previous methods of fixation monitoring, like the Hegel-Krakow method, are not commonly used now, wherein the stimuli was projected at blind spot from time to time by the machine to detect if the patient was shifting gaze. But now the gaze tracking is more superior software, and sometimes the head tilt can rotate the blind spot and give a pseudo loss of fixation. So the fixation losses should not exceed more than 20%. This is the gaze tracking method that is available. So false positives are basically a no-no for a printout. If you see a lot of false positive, you can discard that printout as unreliable. It happens in trigger happy patients, wherein the patient, even if not perceiving the stimuli, keeps pressing uh, on the and keeps clicking on. So in the false negative, what happens, as the test proceeds, some patients who are very old or fatigued can have inattention during the progression of the test. So the peripheral points are not taken up correctly by the patient. It can also happen in advanced diseases. So it's not like always false negatives should be discarded. We can take it with a pinch of salt and not discard the field as such. The total deviation plot shows the difference at each test point between the patient's threshold and the normal value of the given age. The pattern deviation plot shows the localized loss and is adjusted for the general height of field of vision. So the seventh highest sensitivity value relative to the age normal is taken to represent the general height of hill of vision, that is the 85th percentile. And the pattern deviation of this point thus becomes 0. Coming to the global indices, the mean deviation is the average overall severity of visual field loss with more weightage to the central points. And the pattern standard deviation is the index of roughness of the hail of vision, the degree to which the numbers in total deviation plot are dissimilar to each other, and the standard deviation around the mean that constitutes the mean deviation. So in very advanced disease, again, it plateaus. So again, a low PSD appears in a very advanced disease because overall roughness of the hill of vision disappears. Small term fluctuations are the intra-test variabilities, and the corrected pattern standard deviation is the PSD corrected for short-term fluctuations. So in Octopus also, we have certain indices like the mean deviation loss variance, short-term fluctuation, and the corrected loss variance, which are similar and comparable to the Humphrey. So coming to the glaucoma hemifield test, it has 5 zones and primarily directed at diagnosis of glaucoma, not other diseases like outside normal limit, borderline, generalized reduction in sensitivity, abnormally high sensitivity, and within normal limits. These are the 5 statements that would appear as a GHT. So these are the 5 zones which are being tested and compared in both hemifields. For the PEGs, the Anderson's criteria is very important for their exam point of view and also to understand. So pattern deviation plot showing a cluster of 3 or more non-edge points. Non-edge points is to be focused on that have a p-value of less than 5% and one of which has a p-value of less than 1% in the expected location, that is the Jerem's area. So and a PSD or a corrected PSD of less than 5%, and a GHT reading abnormal. Plus, a reproducibility in at least 2 consecutive fields is to be kept in mind. And then it has to be correlated clinically. Clinical correlation is of utmost importance. Certain case scenarios here, the first visual field had a high false negative, but when we did another visual field in the same patient in the left eye, it had less fixation losses and less false negative, but the field was essentially similar. So we can keep a field which is in advanced diseases, which has a high false negative. So this was my case of Sturge-Weber syndrome, wherein it had asymmetrical glaucoma. In the right eye, there was superior-temporal thinning and the inferior inferonasal and inferior developing arcuate. but the left eye was essentially normal. So in this, which is a non-glaucomatous field damage, so this is a case of AION which I encountered and had an inferior altitudinal defect in the right eye. So another case. So this is to be paid attention to, again, like Dr. Anu already mentioned, that not just by looking at the field and the printout of the field, we should also go and look at the fundus of the patient. So this was a lasered fundus, and therefore these field defects appeared. And it was not a glaucomatous change. Again. So in this, if we look at a field wherein the pattern deviation is worse than the total deviation, we can straightforwardly discard this field as a high false positive. And if you see this very pale gray scale, then also you know that it is a high false positive. Next is another case scenario. The students can recognize the clover leaf pattern, which is a high false negative. So as and when the patient moves to the peripheral points, the inattention appears or the fatigue appears, giving this typical clover leaf pattern. So coming to another scenario. This one I want to discuss. So if you see that the edge points are suddenly dropping to 0, that means that the patient is not, it's not because of the patient response, it's because of some rim or some artifact that is coming up and covering that field. So suddenly it is dropping to 0 in this area. So that means it's a rim artifact. Okay, and one more I would like to discuss. So this one is not a glaucomatous field for the students. This is a generalized reduction in field. So you should look for media opacities like cataract and not think that this is, by looking at this, that this is a glaucomatous damage. Okay, I'll end here. Thank you everyone for your patient hearing. And thank you, Bharti ma'am, for giving me this opportunity.
Thank you all, Jharkhand glaucoma speakers, as well as our national speakers, Professor Kirti ma'am, Professor Parivardhini ma'am from Shankar Netralaya, Professor Ratini from Shankar Netralaya, Professor Swati from Arvinda Eye Hospital, Professor Devendra from Arvinda Eye Hospital. So we had very reputed national glaucoma faculties from very reputed national institutions. So today we had our preferred practice pattern session with the national faculties as well as Jharkhand Ophthalmological Society's PG teaching session also. So I think both the sessions have benefited the local ophthalmologists as well as postgraduate students. And I'm really thankful. And in future also, I will take you people the help and will make a 1-year module for the preferred practice pattern for the ophthalmologists and for the PG teaching also. And I hope our local JHOS glaucoma surgeons, they will also help us in an enthusiastic way. Thank you, everyone.
Thank you, ma'am.
Thank you. And all the faculties from Shankar Netralaya and Arvinda Eye Hospital, they have stayed till so night. They have a very busy schedule. And in 1 day notice, they have come. That's a big part. Dr. Swati, I talked to you yesterday evening, late evening, when I was conducting cornea.
Yes,
and
ma'am.
other doctors, the Shankar Netralaya people, I talked today morning.
Oh my God.
Yes, today morning. So I spoke to you and Dr. Swati and Dr. Devendra yesterday evening when I was running the cornea one. And today morning, the Shankar Netralaya people pitched in. I spoke to them today morning only. So they are also very, very senior. Dr. Parivardhini is very senior. Thank you. Thank you so much.
Right, everyone. Thank you so much, ma'am. Bye.
Bye.
Thank you, ma'am. Thank you.
Bye.
Thank you, ma'am. Thank you. Thank you, ma'am.
Bye. Bye all.
Thank
Bye
you,
all.
everyone. Bye.
Thank you. Thank you, Dolly. Thank you, Rashi.
Thank you, Bharti. Thank you.
Today it finished very early. Very early. Yes. The glaucoma, the cornea
May I
people,
end
glaucoma
the
people.
screening, ma'am?
Finished a little earlier.
Ma'am, may I end the
Very
screening, ma'am?
early.
Ma'am, may I
Yes.
end the
I had
screening?
some